So CPS is a cognitive behavioral approach that's designed to, for working with children who are challenging. And by challenging, we mean kids who have explosive behavior, highly aggressive behavior. I mean, you can pretty much fill in the blank as to what it means to be challenging. They're the kids that are on your units. And it was developed by Ross Green, who's a psychologist. So one thing that CPS really encourages is to think about why challenging kids are challenging, because the answer to that question from a CPS perspective really drives what the intervention is going to be. So we can't, all of you came up with all different, there are some similarities in the ideas that you came up with, but you can think about, depending on what your theory is, that's going to influence your intervention. So as an example, Ross told me this story about, he does a lot of consultation on inpatient facilities to help them implement collaborative problem solving. So he was at a unit that was having a lot of problems with one particular child, a 10-year-old girl who had the traumatic history of abuse, physical and sexual abuse. Her father wasn't in the picture. Her mother was a prostitute and a drug addict. So she had a lot of the things that you all were talking about in terms of the family problems. She was on the unit, and she was presenting a huge challenge because she ingested sharp objects. Big problem on the unit. So Ross was speaking to her primary clinician and asked the clinician, what's your theory? What do you think? Why do you think this child is ingesting sharp objects? And the clinician said, well, I believe it's a metaphor for her of expressing the pain that she has experienced throughout her life. So Ross nodded and said, okay, so what intervention have you kind of implemented with her based on that belief? So the clinician had given this girl a rubber band to wear on her wrist and said, whenever you feel like ingesting a sharp object, instead of doing that, snap the rubber band so that that's as a different way of dealing with it. So kind of made sense based on the clinician's theory for what was going on with this girl. And Ross asked, well, how did that work? And the clinician said, well, it didn't work. She swallowed the rubber band. So in that example, the clinician had a theory. She hadn't really tested out the theory to know if that really was what was driving the behavior. And based on the results, clearly that wasn't quite it. So collaborative problem solving's theory of why challenging kids are challenging is because these kids are delayed in the development of crucial cognitive skills, or they're not able to use those skills in the situations when they're most needed. So it's kind of thinking of it like a learning disability. A child who has dyslexia can't read because of that learning disability. It's not because they're not motivated to read, it's because they lack the skills. And if you believe that they lack the skills, then what is your intervention, what is part of your intervention going to be? Teaching them the skills. So the skill deficits that kids often have are listed here. And some of you mentioned these in your kind of theory of why challenging kids are challenging. So the answer to why from a CPS perspective is because they're lacking those key skills that were just listed. When are these kids challenging? I mean, are the kids challenging all the time? No. They're challenging in what Ross describes as the clash of the two forces. So one force is that they're lacking those skills, and then there's an environmental demand. When that meets, that's when you have the challenging behavior. So any situation where the kid is lacking skills and there's a demand for that skills, you can predict that that's going to lead to challenging behavior. And the unsolved problems are the specific condition where there is the demand for a particular skill and the child doesn't have the skill. So CPS really focuses on identifying those unsolved problems, because if you can identify them, you're better able to predict when you're going to have the challenging behavior. And if you can predict it, you can, to some extent, prevent it. And so that's a key concept in CPS. So the goals of CPS are, one, to help the adults identify the factors that are contributing to challenging behavior. So remember that list of kind of domains of skill deficits. In CPS, you really want to do a very careful analysis of what are the cognitive domains that the child has limitations in. That's really critical. And then to help adults learn what are the different options for dealing with the unsolved problems that the child has. And then lastly is to help the adults and children, as the model is called, work collaboratively to solve those problems. The first is Plan A. And that really that's pretty much what adults typically do. It's the imposition of adult will. So go to your room because I said so, basically. And if the child doesn't respond, it's more of imposing the adult will. And that typically leads to an escalation of challenging behavior, because that's a clash of the two forces. The child is lacking the skill to be able to respond appropriately to an adult request, and the adult is making a request. So that's Plan A. Plan B is, that's where the collaborative problem solving really comes in. It's work, it's more of a negotiation. And there are different steps involved in doing Plan B. So the first is to kind of express, it's called the empathy step. It's not about expressing empathy, but it's about finding out what the child's concerns are. So it might start off by saying, let's take for the example that you want the child to go to their room and the child hasn't. You might say something like, I noticed that you're not going to your room, what's up? That would be that would be the start of it, but that's doing Plan B in an emergent situation. Really, for collaborative problem solving, you want to kind of figure out what's going on for the child in these situations before it becomes an issue. But it starts out by kind of finding out what exactly are the child's concerns in any of these situations when there is an unsolved problem. That word, invitation, is a key component of the empathy step. It's really inviting the child to tell you about what's going on, what's the concern. So the first part of Plan B is gathering information, inviting the child to share information about what exactly is the concern. So it often starts by, I've noticed that you've had trouble doing your homework. What's up? As opposed to, why aren't you doing your homework, or do your homework? It's asking the child to give you some information that you're going to be able to use. And then the next step is for the adult to share their concern. So you don't want to just know what the child's concern is. You want the adult to share their concern. So this kid is saying, I can't do my homework because I don't do my homework because I have trouble writing. So the dad might say, so I understand that you have trouble writing. My concern is that when you don't do your homework, you get into arguments with mom, and then you get in trouble at school for not doing your homework. So the dad is kind of laying out his concerns on the table. And then the last step, which is the kind of where the problem solving comes in, is for both the child and the adult to brainstorm realistic, and this is key, mutually satisfactory solutions. So it has to be something that you can do, and it has to be something that's going to make both people satisfied or happy. So, I wonder if there's a way that we can help you have more comfort, make it easier for you to write and for you to do your homework. Like, let's think about some solutions for that. And then you pick a solution and you try it out, and if it doesn't work, you're kind of going back to this step. So that, in a nutshell, is the Plan B part of collaborative problem solving, and that's the critical component of collaborative problem solving. Quickly, there have been 2 studies that have implemented CPS on inpatient settings, and both studies found that with successful implementation, there was significant reductions in the use of both seclusion and restraints on these units. So the first was in 2006, and it was on a 13-bed locked unit. The They got CPS training for a year, and it was fairly intensive supervision, about 2 hours a week for the staff. That they did it on the unit. And this shows the decline in the restraint episodes before and after CPS implementation. So before, there were 281 restraint episodes on the unit. After, there was 1. It doesn't even show it. You can't even see it on the graph. Again, this is not a study that met the gold standards that we talked about before. It's not a controlled study, but still, they're pretty impressive results. And then in a larger study, this was at Yale New Haven Child Psychiatric Hospital. Again, a small unit, 15 beds. They got 6 months of training, and they looked at data 3 years before CPS and a year and a half afterwards. There were 755 kids admitted during that time, and here are the results. So both restraints that are in the blue and seclusion in the red went down significantly once CPS was in place on the unit. So it seems to, based on these results and the experience, a lot of inpatient units and residential settings, even in juvenile detention settings, have implemented CPS with similar success, but it is something that requires the whole unit. So not, the milieu staff, the doctors, the nurses, everybody has to really be on board in this, and there has to be a lot of discussion with the unit as a team about how they're doing this, because in order for it to work. And the key component in addition to those, the plan B, is teaching the skills that are lacking, that are contributing to these challenging behaviors. So on your units where the kids are staying on average about 6 months, there's the time to both identify what are those lacking skills and then teach kind of the replacement behavior, teach the skills so that the goal would be at the end of the stay, the child has kind of their skill in any one of those deficit areas has increased, so that when they're leaving the unit, they're at a better place than when they came in. That certainly is the goal. This is in your slides, just some resources for if you're interested in CPS. The website, the first one, actually has some radio programs that Ross Green did specifically talking about implementing CPS on inpatient settings. And also in the book, Treating Explosive Kids, there's a whole chapter on doing CPS in inpatient settings. So that's CPS. Another kind of approach that has similar, some similarities with CPS is motivational interviewing, that also can be done on an individual basis, but also could be a unit-wide way of really having conversations with children. It's basically motivational interviewing is a collaborative conversation to strengthen a child or person's motivation to change. So it's really kind of meeting the kid where he is and having a conversation that's trying to move them along in terms of change. And it was originally developed to work with problem drinkers. The key elements of motivational interviewing are listed here. So it's really a conversation. It's collaborative, so it's not like I'm the doctor and I say that you need to change this behavior. It's, we're on the same plane and we're having a talk about this. And then it's evocative in terms of trying to elicit motivation for change from the child or the adult that you're working with.